Welcome to the July issue of the Journal of Vascular Surgery, Venous and Lymphatic Disorders. There are 4 papers that we would like to highlight this month. The first paper, which is the editor's choice, is called Treatment of Popliteal Vein Aneurysms and is by Nobeni and co-authors from Germany and Switzerland. 39 patients were diagnosed with popliteal vein aneurysms, defined as 2 times the normal vein diameter over a 25-year period. All were offered either lifelong anticoagulation or surgical repair when the venous aneurysm was greater than 2 times the size of the normal popliteal vein. The mean size of the aneurysms that they treated in their series was 23.3 millimeters, and 79% of patients were selected the treatment with either anticoagulation or surgery, while 21% only agreed to surveillance alone. In follow-up, patients with an aneurysm that was larger than 20 millimeters had a greater risk of popliteal vein DVT. Those who elected treatment rather than surveillance chose surgery in 94%. The authors concluded the popliteal vein aneurysms are a rare disease that should be treated when larger than 20 millimeters in diameter due to the risk of DVT. Either surgery or anticoagulation are appropriate treatment options. The next paper, defining the utility of anterior-posterior venography in the diagnosis of venous iliofemoral obstruction by Lau and co-authors from New York, compared the accuracy of venography in the AP view to IVUS in patients treated for iliofemoral chronic venous insufficiency who had a greater than 50% stenosis of the proximal vein. They evaluated venograms for stenosis location, thinning of contrast, collaterals, and vein pancaking in 86 patients who had imaging studies of the right and left iliofemoral veins available for review prior to iliofemoral vein angioplasty and stenting. The accuracy of venography at each location using stenosis of greater than 50% as IVUS criteria for proximal obstruction demonstrated that the venogram had a less than 50% sensitivity in all locations on the right and left, while venography combined with other findings of pancaking and collaterals had a sensitivity of greater than 90% only in the left common iliac vein. IVUS changed the treatment plan in up to 50% of patients. These studies indicate that venography provides indirect evidence of left common iliac vein stenosis, but has a low sensitivity in most iliofemoral locations. IVUS is superior in demonstrating iliofemoral stenosis when the angioplasty threshold and stenting of the stenosis is greater than 50%. The third paper for this month is by Bademci and co-authors from Turkey and is entitled Single-Center Retrospective Review of Early Outcomes of Radiofrequency Ablation versus Cyanoacrylate Ablation of Isolated Great Saphenous Vein Insufficiency. They compared their initial experience with cyanoacrylate glue and compared it to radiofrequency ablation in a retrospective study of 159 patients, with similar numbers receiving each treatment. Saphenous veins were of similar size, that is approximately 7 millimeters, in each of the treatment groups, had similar lengths of vein treated, that is approximately 30 centimeters, with each modality, but the treatment time was 10 minutes longer with radiofrequency ablation due to the need for tumescence. Closure rates were similar up to 1 year, and complications consisting primarily of reversible paresthesia were slightly higher in the radiofrequency ablation group. The authors concluded that both procedures are effective, significantly improve symptoms, and are durable up to 1 year. The final paper highlighted in this month's journal is entitled Routine Use of Ultrasound to Avert Mechanical Complications During Placement of Tunnel Dialysis Catheters for Hemodialysis by Arshina and co-authors from New York. They reviewed their experience with 1,600 tunneled dialysis catheters placed in the proximal neck veins under ultrasound guidance. Using ultrasound and a micropuncture technique for patients with a low intravascular volume, they had no hemo or pneumothoraces, with only rare non-life-threatening arterial branch injury after placement, which required a revision. The authors advocate routine use of duplex ultrasound during tunneled catheter placement and believe that this procedure can be routinely accomplished with a negligible risk of hemothorax, pneumothorax, or carotid artery injury. We hope that you enjoy this month's JVSVL and the many other excellent articles in it, and thanks for your attention.